introduction. It's a pleasure being here. Again, I'm Isaac Mubezi. I'm a general surgeon here at the Hope and Healing Center and as well as Iganga District Hospital. But I'm passionate about global surgery. And this topic is a very good topic that I'm happy that many of you have joined and some more are joining. And it is a huge pleasure to have our presenter today. Is a professor of radiation and a professor of radiology and surgery in the division of vascular and interventional radiology at Mount Sinai Hospital in New York City. Is a very well-known researcher, but also has done a lot in the field of medicine, surgery, radiology, vascular, and all that kind of stuff. So we will be hearing from Professor Ed. It is a pleasure to have you today, especially talking about the use of microwave ablation for the treatment of both primary and metastatic liver cancer. And he will tell us more, but this is going to be done here in Uganda, here within the region at Kyabirwa Surgical Center. So I don't want to take much of his time. I would love to open the floor to Professor Edward Kim. You're welcome to this webinar.
Thank you so much, Isaac, for the kind introduction, and thank you to the organizers for the invitation. I am extremely excited to be a part of this and also to be traveling to Uganda to help foster relationships and to bring ablation to the patient population there that we could probably use in many different ways. I'm going to share my screen. I sent a request to share my screen. And I'm going to be today talking about, let's see, about microwave ablation, specifically for primary and secondary liver cancer. Is it sharing?
Yes, Prof, we can see the slide.
Oh, you can? Okay, great. All right. Is it sharing the right setting or no? That should be okay.
It's okay now.
That's wonderful. That's wonderful.
Okay, great. All right, so I'm going to present the use of microwave ablation in the treatment of primary and metastatic liver cancer, and I'll take any questions afterwards. I am a professor of both radiology and surgery and interventional radiology, and more specifically, the practice of interventional oncology at Mount Sinai. We are one of the largest referral centers for liver cancer within the United States. And so that is where the bulk of my practice is. I would say 90% of my practice focuses on liver cancer. And microwave ablation is certainly one of the tools that we have in a minimally invasive fashion to treat liver cancer. My presentation is going to be heavily focused on data, and where the real optimal patients are with microwave ablation for liver cancer. So microwave ablation, which is a little bit newer than radiofrequency ablation, has probes that function as antennas for externally applied energy. And so radiofrequency ablation, you need a grounding pad and then an active source to deliver the energy to your target tissue. Whereas microwave ablation, the probe itself is the feed point. And what it does is it sends short wavelengths into the tissue and causes water molecules to undergo friction, and that causes coagulative necrosis. And many of you who are on this webinar are certainly aware of this technology because bovine needles function in a similar fashion. Now, the initial papers that came out with microwave ablation for liver cancer were published in 2012 out of the University of Wisconsin, which showed a faster and a larger ablation zone created with microwave ablation probes compared to 3 radiofrequency ablation probes. And so microwave ablation here in the United States has really overtaken radiofrequency ablation as the preferred heat-based ablative modality for the treatment of liver cancer. And this is a study that was published that again shows that microwave ablation generates higher temperatures in tissue at a faster rate than radiofrequency ablation. Both technologies, radiofrequency ablation and microwave ablation, use the deposition of energy to create cytotoxic heat. 50 degrees Celsius is the threshold for where above that you get tissue coagulation and irreversible lethal heating. Below the 50 degrees Celsius, sublethal heating is performed, and you can also use that to your advantage with the increased blood flow to deposit chemotherapeutic agents or even radiation-based agents when you inject them in a transarterial fashion. So the first part of my lecture will focus on HCC, and this is the Barcelona Clinic Liver Cancer Guideline. And these are recommendations based on high levels of evidence for the utilization of various therapies. When it specifically comes to ablation, whether it's radiofrequency ablation or microwave ablation, the very early stage is where you see ablation recommended. And the level of evidence there we will go over, but it's really as a curative intent procedure with a parallel or equivalency to surgical resection in selected patients. The American Association for the Study of Liver Disease, which gives recommendations in terms of transplant, resection, and the guidance of the liver, really recommends thermal ablation for lesions that are up to 3 centimeters in size as an alternative to surgical resection with a level 1 strong recommendation. The NCCN guidelines, which is used by medical oncology heavily within the United States, also recommends local regional therapy in general, but ablation is preferred for lesions if you can get a complete ablation zone with good margins, as well as arterially directed therapies and radiation therapy. And they also recommend local regional therapy with ablation when patients are deemed unresectable HCC. And when it comes to patients who also have concomitant extrahepatic disease or metastatic disease in the setting of HCC, if systemic therapy is not working or they're progressing in the liver despite systemic therapy, then a recommendation is to reassess the patient and to consider potential surgical alternatives as well as local regional alternatives like ablation. And ablation in terms of recommendations, microwave and radiofrequency ablation are seen equivocal, but there are certain recommendations in terms of size and location of lesions for when ablation is appropriate that we'll go over as well. So the BCLC, again, going back to this is the most commonly used treatment stage algorithm, I would say globally, for a multidisciplinary task force to discuss the the treatment of patients. And that usually here includes hepatologists, hepatobiliary surgeons, surgical oncologists, interventional radiologists, as well as medical oncologists to discuss care for the patient. Now, in the early stage, these are patients with good underlying liver function and usually solitary tumor with 3 nodules up to 3 centimeters in size. They don't have vascular invasion or extrahepatic spread. So you're really looking at curative therapies with excellent 5-year survivals. And this would include therapies such as surgical resection, transplantation, and percutaneous ablation or microwave ablation. Surgical resection, we'd love to do resection on all the patients, but only about 20% of patients are eligible for surgical resection because they may have other comorbidities or they may have portal hypertension, which excludes them from a surgical resection. So 5-year survival rates should be on the order of greater than 70%, but it drops to 50% with portal hypertension. It drops to less than 30% if they have portal hypertension and liver dysfunction. Transplantation is known as the only true cure because you take out the disease underlying liver and then implant a new liver. But obviously, this is not perfect because there have been quoted recurrence rates at 5 years. And there's a long waiting list within the United States as deceased donors are the primary choice for liver transplantation here. So you need a therapy that will bridge those patients who have HCC to a potential curative transplantation. So the early evidence that came out in favor of radiofrequency ablation in the setting of liver cancer was published by David Liu out of UCLA, I think over 15 years ago. And he looked at explant tissue with radiofrequency ablation and found that the tumors that were up to 3 centimeters in size had the greatest percentage of complete pathologic necrosis of 83%. Location was also important when it was in a non-vascular location, not next to a portal vein or hepatic vein or artery. Those had an 88% complete pathologic necrosis rate. This was a study by Weinstein in 2018 that looked at overall survival and 5-year overall survival of 61 to 86% for lesions up to 3 centimeters in size when ablation was performed. And microwave ablation was similar to RFA for lesions up to 2 centimeters with an overall survival of close to 80% at 5 years with no significant difference in recurrence-free survival or time to progression compared to radiofrequency ablation. When we look at outcomes of microwave ablation in the early stage, Laura Crocetti out of Italy published on the efficacy of evaluating with histology post-transplantation. So 30 patients with 36 nodules were studied, and 1-month complete response rates on imaging was in excess of 83%. And on pathology review, 78% had a complete pathologic necrosis. So very good correlation between the imaging and what we see on pathologic specimens were demonstrated by the group from Italy. In comparing ablation head-to-head with surgical resection in the HCC population, this was a prospective study published out of China in the Annals of Surgery in 2006, 180 patients, single tumors up to 5 centimeters in size with good CHOP-Hughes status. And they demonstrated similar 1 to 4 year overall survival rates between ablation at 96%, at 1 year, 93% for resection, and then 69% survival rates at 4 year for ablation and 64% for resection. The one difference that they did find in the study comparing surgery to ablation was that there were higher rates of major complications with resection at 56%, versus 3% with ablation. This was a study published in Journal of Hepatology out of that group as well, and showed 168 patient population, lesions up to 4 centimeters in size, that again showed similar survival rates, 3 years at 67%, 75% for resection. So head-to-head looking at resection versus ablation. And this is a randomized control trial that was published, the SURF trial, out of Japan in 2021. This was an RCT of 49 institutions with well over 300 patients, looking at ablation versus resection. 90% of the patient population had single lesions, and the recurrence-free survival was similar between both groups. And so it was not statistically significant between resection and ablation. What they noticed was there was a longer intra-op time and hospital stay with more adverse events with resection versus ablation for, again, lesions up to 3 centimeters in size. And so when it comes to ablation, specifically in the setting of primary liver cancer or hepatocellular carcinoma, thermal ablation is seen as an alternative to treatment to surgical resection for lesions up to 3 centimeters in size. There's a wealth of evidence to support ablation as an alternative. Complete pathologic necrosis is highest in lesions, again, less than 3 centimeters as well. And numerous guidelines have incorporated ablation either as an alternative to surgery or complementary in well-selected patients. Certainly, ablation can be performed in lesions greater than 3 centimeters in size, but the most optimal results are with up to 3 centimeters. Switching gears on my lecture now and looking at the evidence with metastatic disease. Obviously, metastatic disease started elsewhere and then deposited to the liver. And I think the most common metastatic disease that we see is colorectal cancer. And in 2024, the American Cancer Society estimated that there were over 150,000 new cases with an estimated 53,000 deaths from colorectal cancer. And certainly the incidence, surprisingly, in the US is increasing for those under the age of 55. 50% of these patients do develop liver mets. I think that is where the drainage from the colon is that it drains into the liver and then metastatic deposits occur there. 10 to 15% undergo hepatic resection with a 5-year survival quoted between 31 and 58%. And so not a lot of patients are eligible for what we would define as curative resection. Systemic therapy can involve biologic agents and multiple chemotherapy regimens, but the median survival is only at 20 to 22 months, and 5-year survival with systemic therapy alone has been quoted at 0%. And so certainly we need more durable regimens, and in an era where checkpoint inhibitors has exploded with various cancer states, there is yet to be a positive study in favor of checkpoint inhibition in colorectal cancer. So where does ablation fall into the spectrum with metastatic colorectal cancer? 5-year survivals have been quoted at 17 to 51%. I think very similar to surgical resection, but again, the patients have to be well selected. There's insufficient data with randomized controlled trials currently. But recently there has been a trial that was published, and we'll go over that trial. The literature search from 1998 to 2015 results in over 5,000 either case reports or studies that have been published. And so there was a task force that met to discuss what are the best recommendations, what does the literature recommend in terms of ablation in the setting of metastatic colorectal cancer. With percutaneous radiofrequency ablation, looking at open resection, looking at combined open resection and ablation, and open radiofrequency ablation and laparoscopic radiofrequency ablation, specifically in the setting of metastatic colorectal cancer, you can see that the mortality rate from the procedure and complication rates are much lower with percutaneous radiofrequency ablation versus everything else, either open or laparoscopic radiofrequency ablation. And the hospital stay is significantly less, quoted between 1 and 2 days of a hospital stay with percutaneous radiofrequency ablation. In terms of local recurrence rates, you can see with open radiofrequency ablation, anywhere between 6 to 43% local recurrence rates. with laparoscopic about 5%, and then with percutaneous, certainly you can get a percentage of patients with a much lower, higher local recurrence rate. And why is that? Well, it's because with percutaneous, you have to be confident with the imaging. It's also which patient size characteristics in terms of the tumor size that they chose. And so when you look at the size of the lesions, most of these were less than 3 centimeters in size. But the local recurrence rate is an issue. And I think targeting is important, whether it's under ultrasound or CT. Exact targeting when you use percutaneous ablation results in the highest outcomes. So small to medium-sized tumors are optimal, very similar to hepatocellular carcinoma, metastatic colorectal cancer. The ideal size is up to 3 centimeters in size, and that's because most of the microwave ablation probes generate at their largest with a single probe about 5 centimeter ablation zone. And so you have to achieve or aim for a 1 centimeter margin. And this leads to decreased local recurrence rates, which leads to improved overall survival. But you can choose larger lesions up to 5 centimeters in size, as the data also supports that, as long as you're getting confirmation that you're getting good margins for those tumors. Really, the best results are achieved with solitary tumors, 3-year survival quoted at greater than 80%, with 5-year survival close to 51%. And a strong consensus of up to 5 tumors can be routinely considered for ablation, up to 9 tumors in well-selected cases. In terms of complications, certainly bile duct proximity may be an issue. Central bile ducts near the hilum should be avoided in most cases, as this can lead to biliary stricture and bilomas. And cholangitis and abscess formation are certainly possible the more central location you go with bile ducts. When it comes to blood vessels, again, the microwave energy is short wavelengths that deposit into the surrounding tissue, causing water molecules to have friction and then create heat and coagulative necrosis. If you're near a large blood vessel, it can do 2 things. It can create a cooling effect by sumping the temperature away, and also the water molecules in blood vessels are constantly moving. So even though you agitate it for a second, it'll move and dissipate your energy deposition. If there is a small blood vessel nearby or a slow flow blood vessel, for instance, individuals with portal hypertension or cavernous transformation of their portal, that could actually lead to blood clot formation after the procedure and thrombosis of the adjacent blood vessels. So care needs to be taken. There is also an increased risk of tumor recurrence in tumors next to blood vessels. So techniques can be used to either increase the power or to even embolize transarterially prior to your ablation to mitigate the risk of cooling. When you're close to critical structure, care needs to be taken to create a safety margin. If there is potentially bowel in the way, you can move that bowel with air, or you can inject sterile water into the space as what we call a technique called hydrodissection to move critical structures out of the way. But keep in mind, for instance, in the example shown here, that this patient had undergone a prior colon resection, and so there's adhesions and scar tissue. And so with a recurrence adjacent to that colon, and you can see the surgical suture material here, you cannot move that away because of the adhesions with hydrodissection. And so this is a case that we would avoid ablation for, as the colon can get collateral damage and perforate from the ablation. In terms of maximizing local tumor control, you want to obtain adequate ablative margins. Again, aim for margins similar to resection, 1 centimeter surrounding the tumor. So that's why a 3 centimeter tumor is optimal, as 1 centimeter will lead, 1 centimeter margin will lead to a 5 centimeter ablation zone, which is again the largest ablation zone from a single probe that most manufacturers make. Visualization of the extent of the tumor is also important, so contrast enhanced imaging is highly recommended when doing these procedures, as you can see the borders, and then ensure an adequate margin. From an operator experience, from a consensus paper of multiple high-level users, minimum of 100 liver tumors ablations is recommended, and it's correlated with decreased recurrence rates. Certainly, general anesthesia is preferred as moderate sedation. While it can be done under moderate, general anesthesia affords respiratory motion quality and accurate targeting. And pre-procedure imaging usually should be within 2 weeks, as MCRC doubling time is about 100 days, and tumors can grow if the imaging lapse is too long. And ablation monitoring with post-contrast enhanced imaging is recommended. When it comes to timing of chemotherapy with ablation, you can divide it into neoadjuvant and adjuvant chemotherapy. Neoadjuvant is really advocated for potentially lesions that are much larger upon presentation. But if you can decrease the size of the lesion with neoadjuvant chemotherapy, potentially you can downstage that tumor and then provide consolidated therapy with ablation for a curative intent. In terms of adjuvant chemotherapy, the strongest evidence after liver resection, there seems to be a promising trend towards improved survival with adjuvant chemotherapy and may institute 2 weeks after ablation. Now, this is a study that was just published this past year in Lancet Oncology called the Collision Trial. And this has been making a lot of headway, being incorporated into a lot of guidelines. I was part of a committee that submitted to the NCCN for a change in recommendation to bump thermal ablation up as equivalent to surgical resection for small size colorectal liver mets. Now, this is an international randomized controlled phase 3 non-inferiority trial. And I think the non-inferiority is important for the study design. This was thermal ablation performed versus head-to-head surgical resection with 10 or fewer lesions in the liver, each up to 3 centimeters in size, without extrahepatic metastasis. So the primary was colon and was only in the liver, met with performance status ECOG 0 to 2, with a primary endpoint of overall survival with an intent to treat analysis. And there was a pre-planned interim analysis for futility and early benefit at 12 months after enrollment of 50% of the planned sample size. Now, the subgroups were broken up into low disease burden with a score of 1 to 3, intermediate disease burden with score of 4 to 10 lesions, and then high disease burden, which was similar to group 3, but would need surgery in the form of hepatectomy. There was a 1-to-1 randomization, surgery to ablation, but the ablation group, they used confirmation software as optional. This is software that is utilized under CT guidance to confirm that your ablative margins are 1 centimeter. 134 in the microwave with 11 in the radiofrequency. When I asked the investigators why there were a preponderance of microwave versus radiofrequency ablation, when this trial started, they only had access to radiofrequency ablation, but after access to microwave, they preferred microwave over radiofrequency ablation for all of their cases. In terms of the procedure details, the experimental versus control group, resection alone, you can see that in the control group, 61% ablation alone. In the experimental group, 80%. Resection with ablation, 18 and 35%. And then in terms of the approaches, it was evenly split between percutaneous versus laparoscopic/open. You can see in terms of the number of colorectal mets on the right side of the chart, the vast majority of these patients had limited disease, either solitary or 2 to 5, with not many patients having greater than 5 tumors. And in terms of the colorectal liver mets type, the target was 78% versus non-target. So most of these lesions were treated. And most of these were all smaller in size, ranging from 3 to 30 millimeters, but the median size being about 13 to 14 millimeters in size. So smaller colorectal mets. Well, at the interim analysis, what they found in this non-inferiority trial was that there was no difference in overall survival. There was a benefit seen in terms of ablation over resection, local tumor progression-free survival. Again, hazard ratio 0.82, but not statistically different from time of randomization. The same goes for distant progression-free survival, as well as patients with local control. What they did find was that there was a difference in the adverse event rate. Total number of adverse events were higher in the control of the surgical resection group versus the experimental or the ablation group. Serious adverse events, 7% in the ablation group, and then 20% in the control group. So mostly bleeding and infection, with length of hospital stay significantly favoring the experimental group of 1 day versus 4 days. So with the interim analysis, the trial was stopped early for meeting the predefined stopping rules, and the conditional likelihood to prove non-inferiority for the primary endpoint of OS of more than 90%, and demonstration of a superior safety profile and non-inferior local control favored the ablation. And so non-inferiority of ablation for MCRC up to 3 centimeters versus resection was essentially proven at that interim analysis, and there was difficulty accruing further due to thoughts of unethical treatment in the control group, meaning putting these patients with smaller tumors in the resection arm for the collision trial was deemed unethical at the interim analysis because there were so many adverse events compared to the percutaneous ablation group. This was published in the Annals of Surgery, and this is across all multiple hepatic malignancies. And if you look at the colorectal group for ablation, you can see it is all consistent with prior published literature, with overall survival at 3 years at 45% for these patient groups. So in conclusion, how do we use percutaneous ablation in the metastatic and specifically metastatic colorectal cancer population? Well, very, very similar to the HCC population. Tumor size, optimal tumor size is up to 3 centimeters, but well-located tumors up to 5 centimeters can be suitable as long as you gain an acceptable margin of 1 centimeters. In terms of the tumor number, 1 to 3 are certainly optimal, but 6 to 9 maximum can also be utilized, and this was also shown with the collision trial as well. Tumor location next to bile ducts should be avoided, especially central bile ducts, as complications may occur. And tumors next to major blood vessels can be suitable, but need to prepare for potential higher local recurrence rates due to sumping of energy and cooling effect of that vessel next to your intended target tumor. And tumors within 1 centimeter of critical tissues, such as bowel and stomach, etc., need to be careful. There are techniques that can be used to push that critical structure away, but in the setting of adhesions, this is not feasible. And again, aim for greater than 1 centimeter margins for metastatic disease. General anesthesia is certainly recommended. And the optimal definition of tumor margins are critical for success. And now we do have randomized controlled trial data published this year in Lancet Oncology with the collision trial that demonstrated a non-inferiority with a better safety profile of ablation, microwave ablation, compared to resection for lesions up to 3 centimeters in size. Thank you very much, and I will take any questions.
Wow, thank you very much, Professor Ed. It's again a pleasure to have you here. Such an insightful and well-researched presentation. I will give the audience the opportunity to ask some questions in regards to the presentation and what is available and what can be done in Uganda. Dear listeners and those that are viewing, you're welcome to ask questions. You can either write in the chat or you can unmute, and then the expert will be able to answer you.
Yeah, and again, I am very excited that we were able, and thank you to Siemens Healthineers and Variant Interventional Solutions to uh, be able to partner with us to bring a microwave ablation, the latest microwave ablation device that they offer, an IntelliBlate, to Kyabirwa Surgical Center. And we'll be doing cases there this next week for patients with liver cancer to provide as an alternative to surgical resection. And so all the data that I presented will be put into practice next week for patients in Uganda, from my understanding, the first ablation device in that country.
Wow, thank you very much, Professor Ed. Again, this region is very blessed to have people like you, and welcome to Uganda. I hope you'll enjoy the Nile River as you come to the Kyabirwa Surgical Center. Again, we in this region we are working at setting the standard and bringing the latest. So this being the first in the country, it is not something to be taken lightly. So thank you again for accepting to partner with us and to bring the latest devices together with your expertise here at Kyabirwa Surgical Center and in Jinja in the Busoga area.
Yeah, I see a question. It says, how many Ugandan doctors have been trained in microwave ablation of metastatic liver cancer? For me, I'm not aware of any, just because this is the IntelliBlate device from Siemens Healthineers is the first device, from my understanding, to be brought into Uganda. We had tried at Mount Sinai to bring in other devices a year ago or 2 years ago, and were unsuccessful as companies had to undergo various red tape to try and get the device into the country, and didn't really want to go through that. But Siemens Healthineers was able to really navigate that quite quickly, I would say in less than a month, and had the device at Kyabirwa Surgical Center in 6 weeks, which is unheard of with probes. And so a lot of just thankfulness from me for them to be able to procure the device and bring it in. And just for your knowledge, that IntelliBlate device was just released within the United States maybe 6 months ago. So many institutions within the United States don't even have access to that device yet. And so truly excited to bring the latest technology to Uganda.
Yes, I think I just want to add my word to what Prof just said. It is one thing to have the trained staff, but it's another to have the equipment. So I think this is already the beginning of having the equipment here. So knowing that Kyabirwa Surgical Center has the equipment, then the training can be done. This is a blessing to have this equipment here. And again, latest produced a few months ago, and it's within the country, and it has made it to Uganda. It's not something simple, so the training can go on. For those of you that are not aware, Kyabirwa Surgical Center is, a daycare center, but doing a lot of minimally invasive surgery and bringing people like Professor Ed, people that are experienced in high tech, to come and train the local staff. So yeah, any other questions?
Wow,
Yes,
I see.
over to you, Dr. Ed. The question is over there.
Yeah, the question is, does it apply to all age groups, including neonates? Uh, I personally don't treat pediatric patients. It certainly can be used, regardless of age group. I'm not aware of a lot of papers that published on treating neonates. So I certainly would not start there. That's Jim Park from Sinai. He has a question. Jim Park is our head of surgical oncology here, and I also see Godwin has raised his hand, so we'll take his question after this. Thank you. What are your thoughts around decreasing the cost of ablation probes or increasing the longevity of probes responsible rather than disposable probes with adequate sterilization techniques? Yeah, I think that's a great question, Jim. Let's just say that our supplier of probes, with the latest and greatest technology that we have at Kyabirwa Surgical Center, the latest technology in terms of the probes, but it is more costly than existing probes. And that's because on it has thermocouples where we can monitor real-time the temperature in that single spot, but along the length of the probe, so we can extrapolate data to see if we have a 3 or 4 or 5 centimeter ablation zone that we're generating. But they are also well aware, and I think part of it was bringing this ablation device to Uganda is that they need to generate less expensive probes. And so they're coming out with a probe that doesn't have the thermocouples, which will be significantly less than the cost of their current probe to try and meet a global demand where cost is a big issue. And in terms of sterilization techniques, I am aware that while the manufacturer and within the US, those sterilization techniques for probe usage is not recommended, that in other countries that they are certainly undergoing sterilization for the use of the probes. I did want to take Godwin's question because he had his hand up. I don't know if you want to ask it live. Maybe he is not available now. Okay. Is the training going to be free? Well, I am just in Kyabirwa just next week. So I am working with the physicians there, Dr. Joseph, just for next week. And so I don't know about anything in terms of training others. Can microwave work in end-stage liver cancer? That's a very good question. End-stage liver cancer has a lot of different qualifications and meanings. For instance, if we use the BCLC staging classification, BCLC-C, or advanced stage, can have a Child-Pugh A, but have vascular invasion that qualifies them. Those patients potentially could be treated. There's also a definition of untreatable TACE where people cannot get further chemoembolization can be treated. But if the patient has large vascular invasion or extremely large tumors, 15 centimeters, I think that is probably out of the scope of ablation. Or if the patient has Child-Pugh C cirrhosis, I would say that the competing risk of cirrhosis mortality probably doesn't qualify for any type of local regional therapy, including ablation. Another question. It's Dr. Joseph, yes. What patient characteristics and disease stage would be considered a contraindication? I think patients with ECOG performance 2 to 3, those who are really debilitated due to their liver cancer in bed most of the day, probably would not benefit from an ablation. From an imaging standpoint, I really do think probably the upper limit is probably 8 to 10 centimeters in size. And that's sitting there doing an ablation with multiple probes or repositioning for probably several hours. I think vascular invasion for me disqualifies the patient as there hasn't been shown to be a benefit in that patient population. With extrahepatic disease, again, I presented some data that in limited extrahepatic disease, when they're progressing on systemic therapy, there could be some benefit to local regional therapy. But again, I think individuals with the smaller tumors really did the best with an ablation therapy. Okay, so if you're not following along in the chat, Dr. Joseph did say there will be an opportunity for training other doctors at a later date. Question from Ambrose: can microwave be used in cancer lesions located in other areas rather than in the liver? Yes, there is a body of evidence to use ablation in other parts of the body. There are probes specifically designed for, let's say, things like thyroid, but the probes used in the liver can be potentially used for kidney cancer as well as renal cell carcinoma. And there have been work with other bodies. There's also cryoablation where you freeze tumors, and those have also demonstrated potential efficacy in other parts of the body as well, things like prostate, the growing body of evidence with breast as well as musculoskeletal metastasis. So yeah, a lot of evidence being generated for that stuff. Nursing care for these patients, follow-up. Usually these, again, this is why the studies I presented, the hospital stays compared to resection were so much lower. We're usually making a pencil-sized tip, the caliber of a pencil size incision on the skin, and then using CT or ultrasound guidance to insert our probe, which is about 14 gauge. And then when we remove it, we're cauterizing the tract. So really low adverse event profile. And I would say that most of the follow-up afterwards, we discharge our patients actually same day at Mount Sinai. They don't stay overnight in the hospital. It's usually with pain meds. If they have any biliary compromise, then we give them antibiotics for the next week or so. And so there really isn't much nursing care that's associated with this. Question: is microwave work in cancer, other organs? Yeah, I think we discussed potentially working microwave in other organ systems as well. Any after effects of ablation to the patient? I would say that, you know, as with anything else, organ within the body, usually stretching mechanism causes pain. So when we ablate near the capsule of the liver, patients do tend to have pain either from ablation of, let's say, an adjacent structure like muscle, or because it causes involution due to desiccation of tissue, and that stretching and inflammation does cause pain for the patient. If it's located in a lesion that is within the liver, not near the capsule, many of those patients don't feel anything after the ablation. They'll feel some soreness in the area that we accessed, some effects from the general anesthesia, but most of the patients actually tolerate ablation quite well. All right, I think I'm all caught up with the questions.
Yes, thank you very much, Professor. A quick question. Are there any no-touch zones? You know, the lesion is small, but are there any zones that you say, no, I want to do ablation on this one? And then the second one is, do you do the fresh sample sections? Do you measure the margins after that to assess the free margins, like we're doing resections, or do you assume it's taken over?
Yeah, no, that's a great question. Both questions are actually great. So in terms of no touch zones or areas that I wouldn't do an ablation for, I actually published a study in Lancet GI about this using a technique that is not available in Uganda, but using radiation-based microspheres called yttrium 90. And that's a transarterial route because and those have been used instead of ablation for certain lesions, because the lesions are in locations that I think have been well documented as having higher complication rates with ablation. And so those locations do tend to be, as I stated in the presentation, near the hilum, higher complication rate. And that, I think, because near the hilum we have critical structures such as the portal vein and the arteries, etc. And the portal vein, it's not so surrounded by a hepatic parenchyma to lead it straight into the peritoneum. If strictures and biloma, etc. I think also lesions. I showed an example where the patient underwent a colon resection. There was adhesions of the colon, the remaining colon and there was a recurrence right at as well as potentially other organ systems. And so anywhere there was surgery and adhesions, I'd be very careful about doing an ablation in that area. And then usually high in the dome of the liver, segment 8, near the lungs, and also on the left side, segment 2, near the heart. You have to be careful because if you puncture the pericardium, it can lead to I'm forgetting right now, but pericardial effusion and then hemopericardium, and then lead to restriction of the heart, as well as near the lungs. It could lead to either a bronchopleural fistula or it can lead to pneumothorax. The pneumothorax, we're not as concerned. We can chest tube afterwards, but still something that your question is really good about margins sampling afterwards. We don't, just because with